Greetings et bienvenue. Je m'appelle Anne Lagacé Dowson. Je vous parle de Montréal. Hi, everybody. My name's Anne. I'm in Montreal. Thank you very much for joining us on behalf of the Canadian Health Coalition. It's super great to be with you this evening. The Canadian Health Coalition, of course, is a coalition of labor groups, public interest and civil society groups, and researchers working on the promotion and advancement of public health across Canada. And I'm super pleased to be with you here from the unceded territory of Tiohtià:ke, known as Montreal, the territory of the Haudenosaunee and Kanien'kehá:ka people, also known as the Mohawks. And the other lovely person on the screen with me today is Colleen Fuller. She is a leading public thinker, intellectual, and writer on healthcare. She told me she is not an academic, but she is certainly an expert. Also an activist who comes out of the labor movement, specifically the Health Sciences Association of BC. She joins us from East Vancouver, the unceded Coast Salish territory of, among others, the Musqueam and the Squamish people. So greetings, Colleen. Super great to meet you on this strange platform known as Zoom.
Thank you. Well, I've got used to Zoom in the last 4 years or so I'm totally comfortable.
Oh, good, because I'm still, I'm still struggling with it, but it's great to be able to see people, and it's great to have all of you with us tonight. So we thought that in honor of the 40th anniversary of the Canada Health Act, we would tackle the 5 main premises of the Act, starting with the main pillar of the Canada Health Act, which is the concept of universality. And everybody I talked to about the Canada Health Act said, no, you've got to talk to Colleen Fuller about this. This is her bailiwick. So here we are with Colleen. Et je tiens aussi à préciser que le webinaire se déroulera en anglais, mais la période de questions sera bilingue. So when we get to the questions, feel free to use either English or French. Vous pouvez vous exprimer pour les questions en français. Okay, so let's start with the first sort of universality 101 question, Colleen. What is universality? What is meant by the term universality in the context of the Canada Health Act?
Well, probably the best definition comes from the World Health Organization, and basically the WHO defines universal health care as a system where people are able to get healthcare services that they need, the full range of healthcare services, that they get them when they need them, where they need them, and as they need them. And I think that their definition of universal healthcare is a lot more generous than the one that most of our own governments in Canada use, and increasingly in Europe also. I think that people are seeing an erosion of the meaning of universal healthcare in a lot of ways. So the WHO would include in its definition of universal healthcare the full spectrum of not just medical services, but those services that you need to stay healthy, to services that you require throughout your lifetime. So when you are older, you would include things like home support, home care, and certainly long-term care, rehabilitation, palliative care, etc. So I think that their perspective is much more generous, and that actually is a good definition of universal healthcare. So you can see that we still have a struggle ahead of us to not just defend what we've got, but also to continue to expand, to really establish a universal healthcare system.
And why is it that there's so much confusion around the concept of universality? It's much bandied about and much maligned in a way, right? Like there are many people who oppose it. There are people who don't understand it. It seems to cause confusion. Why is that, do you think?
Well, I'm not so sure if there's as much confusion as there is a sort of a I think that there are people who are ideologically opposed to the idea of universal health care. And I don't know if there's as much confusion about it. Maybe there is, but I wouldn't describe it that way. I would describe the situation as one in which there are entrenched interests whose interests are undermined or threatened by a universal healthcare system. Certainly the insurance industry is one of them. Other people who believe that healthcare should be a commodity in the market, just like, you know, anything else, and that universal healthcare undermines the right of people to obtain healthcare when they want it, how much they want, et cetera, all of those things. So I think that there, you know, right from the very beginning of our universal healthcare system, the introduction of Medicare in 1966 by the government at that time, the most contentious aspect of our Medicare system has always been the principle of universal healthcare. It's been, people are opposed to it on ideological grounds. They have, you know, deep economic interests that persuade them to oppose universal health care. The medical profession has historically been, you know, anywhere from ambiguous to hostile to universal health care because it infringes on what they consider to be their right to command the money that they want or need to support themselves. So anyway, I don't know if there's so much misunderstanding as a miscasting of what universal healthcare is.
Wait,
And
if I can just jump in, Colleen, I hear people who I would consider generally very sympathetic to public health care saying, well, you know, we probably do need means testing or means, you know, it's not right to give universal access to people who are well off. That just doesn't seem right in the current situation. And I'm that's what's one of the reasons why I wanted to talk to you, is that I'm surprised by how often I hear that from people who I would think would be considered to be allies of public programs in general and public health care specifically.
yeah, well, means testing, I suppose for some people that seems like a fairer system because you're not allowing people to access healthcare for free. And if they can afford to pay for it, they should pay for it. And if
But
they
it
can,
isn't free, right? I mean, we're all paying for it
that's
through the
right.
tax system.
It's a tax supported system.
Right.
But the idea of this kind of targeted funding within the health sector, you know, this has been talked about in Canada a lot. It's been discussed internationally quite a bit. And so because of this interest, I suppose you could say, in targeting healthcare dollars at populations in the most need of accessing healthcare and who confront financial barriers, that you would target those healthcare dollars to them, and then that would be a lot fairer. But it doesn't work, and for a number of different reasons. The most obvious one is that the risk of illness isn't confined to people at the bottom of the socioeconomic ladder. You know, we become ill at different points in our lives. As we get older, we need increased access to health services and supports and so forth and so on. So there isn't like a guarantee that your personal and health conditions are going to remain static, regardless of what your income is, right? So that's one of the flaws in the idea of targeting health dollars to people who are low income. It also,
Isn't it also a form of ghettoization
yes, and
of
that,
people on lower incomes, you know, what people jokingly refer to as the poors?
yes, and it does kind of ghettoize that population. We've had these discussions in BC in the community health center sector about orienting CHCs towards people who have poor health and who are low income earners. And there's been a real pushback from communities against that, and in part because it creates a community health center that is kind of a ghettoized setup, and it ghettoizes that population. It creates resentment in the community because you have people who are accessing services that not everybody else can access, and so forth. So it and that's actually one of the principles of our healthcare system that I remember from many years ago in the late 60s, I guess, in the early 70s, that we are all in the same boat.
It's the concept of equity, basically.
Exactly. And so we all want the boat to stay afloat because we all depend on the boat staying afloat, so to speak. The other problem with targeting services like that, or targeting dollars, is that Michael Marmot, who is this genius on the world stage and has done a lot of work on social determinants of health. He chaired the WHO Commission on Social Determinants. And one of the things he said was that that a health service for the poor is a poor health service. And we know that that's the case, that is, and if we all have a stake in a high quality healthcare system, it means that that part of sort of having that consciousness about it means that we depend on high quality healthcare too. And if we are not getting the poor healthcare service that poor people get, we're not going to fight to defend it anyway. So
Right. And
that's
didn't also the Hall Commission reject means testing as just being too costly to run, like to be able to break it down and differentiate between all of the different income levels? It just becomes difficult and costly to administer. So better to apply it universally and then claw back money through the tax system.
The Hall Commission was very aggressively lobbied by the private health insurance industry, obviously, and also the Medical Association, the Canadian Medical Association, and its provincial counterparts. And they argued that a means-tested system would be a lot better. It would be more cost-effective, and so forth. And they presented to the Hall Commission these very elaborate schemes that targeted, the bottom 10%, then the bottom 20%, and they costed it out, and so forth and so on. Anyway, the Hall Commission, which included a lot of very well-known health economists, including Bob Evans, they also did their own costing, and they basically said that they rejected the proposal outright for two basic reasons. One was that it wasn't cost effective, that the cost of it administering and creating an infrastructure in government to administer a means-tested program was horrendous. And we see that with the dental plan, that the cost of administering means testing, the federal government doesn't have the infrastructure to administer a sophisticated means testing program, and they've shifted it over to Sun Life, who is happy to do it. And so that would be the obvious thing with Medicare as well. The other reason that they rejected the idea of means testing is because it was an incursion into people's privacy, and it undermined people's dignity to have to submit to means testing to see if they qualified for something that they should have a right to. And so that was the argument. The insurance industry and the medical profession were not happy about it, but that's the way it turned out. You see that now also with pharmacare, where the insurance industry, the idea of a universal healthcare system is that the insurance industry doesn't have a role to play in the program that is a universal program. And so they're in healthcare, they weren't completely cut out, which I think is unfortunate, but that's the way it has. That's the way it's evolved, and that's the way it was introduced. So they had a very reduced role in pharmacare. Their role, if we get a truly universal and comprehensive national pharmacare program, the role of the industry will be really significantly reduced. And think about it for a minute. About 70 to 80 cents of every dollar spent on a private health insurance plan is for drugs. So that is really the lion's share of the money that the insurance industry is making. They do provide some services. Obviously, they cover physiotherapy and other services that that unions are able to negotiate and or that employers provide. But the lion's share of our private benefit plans are for prescription drugs, and it's a huge chunk of every dollar that's spent. So the insurance industry is going to lose that if we get a fully comprehensive and fully universal pharmacare program.
I wondered, just to mention to those of us who are joining us, you can put questions into what's called the Q&A just below the screen, and just type whatever you want to ask us about in there, and we'll try and get to it. Just before we started today, an intrepid listener sent us a question. Her name is Joanne Plater, and she wrote in advance to ask, is universality still feasible given Canada's growing socioeconomic disparities and inequitable tax system? Very good question, which brings together a number of the elements we've already talked about. So what's your answer to Ms. Plater, Joanne Plater?
Well, I think that the fight for the principle of universalism is really linked to those other issues. The economic disparities that exist really undermine people's health, and so people who live in poverty, who are affected by racism and misogyny and all of these things that all have an impact on your health and well-being, and will mean that you seek the care that you need in the healthcare system. So I think that's what she's getting at. And so, yes, that's a challenge. And we also do not have a fair tax system. We all know that.
Well, we all just did our income tax, and we were wondering about just how fair the system is, for sure. Yeah.
I know.
Yeah.
I think, and I'm sure that a lot of people don't agree with this, but obviously the wealthy do not pay their fair share of taxes. That is something that we all know very well. But I also think that middle income earners could pay more taxes, that they also don't pay as much in taxes as we need in order to support not just a really good healthcare system, but other programs that we need to keep people out of the doctor's office and out of the healthcare system. So our whole tax system is problematic, and it's a hard question to raise with people, because people do feel that they carry a high tax burden. And the reason that they feel that is because they've got to pay so much money for the things that are not included in our healthcare system or in other social programs. So
Because they're not universal.
Because they're not universal, and because they're not. Yes, that's exactly right. So we're kind of in this weird place where we do need people to be paying more taxes so that we can have a more robust system of both health and social care, and we don't. And so
well, there are people who would suggest that when I think it was Stephen Harper reduced the corporate tax rate from 23 to 15%, that took a big chunk out of our public purse too. So, but I wonder, let's just get back to the Q&A questions, and please do feel free to send in a question, because this is a golden opportunity to talk about a concept which I think needs clarification and is critical to the well-being of our healthcare system. Somebody who's anonymous, an anonymous attendee, wants you to speak more to the opposition interest in universality, in particular from the insurance sector.
Mm-hmm. Well, the insurance sector has played obviously a significant role in eroding some of our universal healthcare services or systems, provincial systems. And I'll give you just one example. In the early 2000s, province by province by province started to delist a lot of outpatient services. And I guess it's started in the 1990s, but it really picked up and was acted upon by governments in the early 2000s. And I always think about physiotherapy. Physiotherapy used to be covered as an outpatient hospital service, and the industry, the insurance industry, was aiding and abetting those companies that were interested in physiotherapy being privatized, and provided. There's nothing wrong with providing services outside of the hospital system, but the way that provinces interpret the Canada Health Act is that if a service is not delivered in a hospital, then it no longer is a hospital service. And even though physiotherapy, for example, is specifically identified in the Canada Health Act as being a service that is a hospital service and cannot be subject to user fees and extra billing. So we're way beyond that now. Those outpatient services are billed privately and they're insured privately. The insurance industry has made a lot of money by insuring these services. I'm sort of wandering I'm wandering all over the place here. I should get back to the point. The insurance industry makes probably 25% of the coverage for insured services. The premiums that you pay go into the insurance industry. So you pay $1 to be covered, and 25% or 20% of that goes to the insurer, and the rest will go into the piggy bank to use when you need it or whatever. And so the insurance industry makes a lot of money. So that's the obvious reason that they oppose universal health care. And what really I find the most aggravating about all of these discussions around universal health care is the progress that the insurance industry has made, I would say particularly during the last 20 to 25 years, in eroding the scope of services that are included in provincial public health plans. And we've seen that, and that means that people are being more and more exposed to the full brutality of the private health care market. The insurance industry, almost everybody in Canada with private insurance is covered under employer-sponsored insurance plans. So people don't go out and buy private insurance for themselves, although increasingly retirees are doing that because they're being cut out of those employer-sponsored plans, and quite significantly. But the number of insured people in Canada who are insured under these employer-sponsored plans goes up and down, depending on all kinds of different factors. The people who are the least likely to be insured in Canada are low-income earners, racialized females. Those are the least likely people to have private health insurance. And that percentage goes up and down as well. So sometimes 50% of working people, I'm not talking about everybody, but people who are employed in the workforce, it can go down to 50% of people who are employed are covered by employer-sponsored benefits. Other times it goes up to as high as maybe 65 or 66%, but it's not 100%. And people confront a lot of discrimination. The insurance industry does discriminate against people, and it's the only industry, I'm pretty sure it's the only industry in Canada who has an exemption from the Canada Human Rights Act, so that they are able to discriminate against people based on age, sex, and disability. Nobody else can do that, but the insurance industry can. Otherwise, how are they going to make money? Because they make money charging high premiums and discriminating against people who are either at risk or who require, have a higher level of need for healthcare services. So they want to maintain this system, and universal healthcare is a threat to all of the ways that they are able to make money by providing coverage for these services. We're going to have a huge fight on pharmacare. The legislation has gone through, that's great, but the insurance the bulk of the money that the insurance industry is making within the broad health system is in drugs. And if they lose that, they're not going to be happy, obviously. But I will be really happy.
And I think probably everybody on this call and everybody pretty much who runs into some of the difficulties you just described will be as well. Let's just move to some more of the questions. Another anonymous attendee who says the two overriding policy objectives under the universality criterion, or the WHO, were to ensure all bona fide residents of Canada are covered and to do so on uniform terms and conditions. How do we avoid this kind of common conflation of the who is covered as a universality and the what is covered, also known as comprehensiveness? Now, this is somebody who clearly knows the Act fairly well. So you want to tackle that one, Colleen?
Well, it's a good question because it's one that we need to think about in terms of pharmacare as well. We've got the program that is being introduced is being described as a universal pharmacare
Yeah.
payer. And single payer is not necessarily universal. And the scope of the pharmacare program is obviously very, very narrow. So I have type 1 diabetes. I'm going to have insulin covered and, so forth. I'm really happy about that. But that doesn't mean I recognize that I don't recognize that there are some really severe limitations to the program that's being introduced. I think it's important and so forth. But my understanding of the options that were being looked at, and this gets to the question that was asked, there were two options. One was that the pharmacare legislation could be universal and cover only a very limited scope of drugs, or it could be very, very comprehensive, and it would have it would not be universal, that it would be a means tested program similar to the dental program, which is really screwed up. And I think of the two options, that the preferable option was what we got. If we had to choose between those two options, we got the better option. And I say that because I think it's easier to expand the number of drugs that will be included under pharmacare rather than to expand the number of people who are covered. And I think it will be easier to do that with pharmacare. It's going to be very difficult to do that with the current dental plan that is a means tested program. And I just think it will be harder to expand it to cover more people.
Okay. Two questions from our listeners, and I would invite you to jump into the Q&A if you have a question and just type it up for us and we'll try and get to it. Somebody who just put in a comment to the effect that economic disparities, notwithstanding the geographic barriers in the country, make delivery of healthcare uneven, especially to isolated Indigenous communities. Interesting observation. And are we confusing universal access to health and universal access to health care? The Canada Health Act speaks to the latter and not the former, question mark.
Mm-hmm. Well, I guess that part of the thinking around universal access was that there are health inequities, right? Because people who are poor and people who are racialized, people who are whatever, that there are health disparities that have to do with social determinants and not necessarily with whether you have access to healthcare. But if you don't have access to healthcare, it does undermine your health status as well. So I don't know if I'm answering the question exactly as the person wanted, but the issue of health status is, I think, one that we don't that isn't talked about enough. And I know that in a lot of the work that I've done over the last 20 years in the community in community health centers, that one of the things that we have suffered from is a lack of funding to address some of the things that create these disparities in health status. And those are not things that can be dealt with in a medical office, but are upstream, and we're not properly funded to do that. In other countries, more traditionally in European countries, and certainly in the UK, although things are being eroded there quite seriously everywhere, but there is a greater integration between social care and health care. And we've never done that in Canada. We've always kept them separate. And that is that is something I think is really unfortunate.
And back to the question, here's I'm going to cut this question comment from Elizabeth Lee because it's a bit long, but she starts off by saying universality was set up to make Canada balance between capitalism and socialism, put forward in the 60s. The right wing fought against it from every angle in the 60s and have now been successful to get rid of just about anything that serves the public. The people of Canada haven't thought about what our grandchildren are going to be able to benefit from after working their whole lives. As for Medicare, pharmacare, dental care, eye care, none of this is universal at any level. It doesn't seem like it ever will be because the political climate stinks, says Elizabeth Lee. When I listen to this discussion on insurance, a two-tiered system and all that, I can hardly stand it. No one who's suffered ill health or been poor would ever, and I'm not too sure where this ends off, but would ever be happy, I guess, with any of these programs. Anyway, I think Elizabeth Lee is expressing a feeling that I'm getting from others across the board. There's a feeling of enormous frustration and unfairness. 6.5 million Canadians don't have doctors. How universal is the system really? I wonder, Colleen, what would you say to Elizabeth and those people who are like, well, it's not really working?
I think I take after my father. I'm a natural born optimist. So I always think that working people will, they have and they will be able to push things forward in the way that, in the direction that things need to go. Having said that, I also know that there has been just a terrible erosion. And not only that, even when Medicare was introduced, it was, there were compromises right from the get-go. And some of those compromises, and I'm talking about the CCF in Saskatchewan, some of those compromises were made to accommodate the physicians who did not want to be working for the government. They wanted to be independent, autonomous, and so forth. And so,
you're talking about the doctors who went out on strike in Saskatchewan.
And the doctors who went on strike, but I mean, that was the reason they went on strike, but it's never changed. As far as I can tell, since that time. Doctors want to be autonomous. They don't want to be salaried employees. They, et cetera. This is one of the weaknesses in our healthcare system because it undermines our ability to have a primary healthcare system, the kind of primary healthcare system that we need. And by primary healthcare, I'm not talking just about medical care, but about the full range of services that we need to stay out of the medical clinic, to stay healthy, and so forth. And so Canada has never, not a single province, and not at the national level either, we have just not dealt with that very basic problem. And universal healthcare, I would say, really begins with a robust primary healthcare system. We have hospital care, and most of us would probably say that we feel very secure if we need to be admitted to a hospital. Not in every way that we would like. You go to emergency, you have to wait forever to get in to see a doctor in emergency, and there are all these problems in the hospital system because they're underfunded, and that's the main reason. There are other reasons, but that's a key one. But we have a greater security of access, in my view, to hospital care than we do care in our own communities, and that has always been the case, and it's got worse. And so I understand where the where Elizabeth, is that her name, Elizabeth, where she's coming from. And I find that really demoralizing and so forth. But it also makes me angry. And I guess anger is what keeps me from feeling too defeated, because I understand a lot of the reasons why we are where we are, and that this has been by design. It's not by mistake. There are people who are manipulating the situation. They're driving the train. They are going in a direction that they want to go in. And so it's not just an accident that we're here. And that means that it can go in the other direction as well. It's not an act of nature. It's a thing that's a political project to erode our healthcare system.
And on that note, I would invite you to consider getting on our mailing list at the Canadian Health Coalition and any number of provincial and territorial health coalitions, which are very active on the ground, and other civil society groups, because there are ways to pressure along the lines of what Colleen was saying, that working people have always had to fight these fights, and sometimes we win them, especially if we're organized. So perhaps consider joining the Canadian Health Coalition or the provincial or territorial health coalition where you live, or the Council of Canadians, which does work on healthcare, and any number of wonderful groups, Canadian Doctors for Medicare. There's many wonderful groups that are sort of exemplary in their analysis and their application of some of the things we're talking about, specifically universality. So I would wonder, Tracy, if you could put the link to the Canadian Health Coalition in the chat, that would be great. And obviously you're already on some of our mailing lists and contact lists, but I think that key element that we shouldn't feel defeated and give up, because we have made this enormous step forward, which is pharmacare. I mean, it was unimaginable. It's the first major step forward in healthcare since the Act was passed in 1984. Somebody's asked you to elaborate on why we're screwed with dental care, because you said that earlier. If you could just elaborate on what you mean by that. And then someone else is asking about amending the Canada Health Act to modernize it. Do we need to amend it? If not, why not? If yes, how would we amend it? So maybe just tackle the question of the problems with dental care and the idea of amending the Healthcare Act, Colleen.
Well, I think, I don't understand all the ins and outs of what happened with the negotiations between the NDP and the Liberals, but the Liberals, they only give as little as they can get away with, and the dental care plan is a real example of that. The problems with it are that, one, it's a means-tested program, and if you're covered under a benefit plan, if you have a dental plan, you're not eligible for coverage under the public plan. If you and somebody was just telling me today that there are all these groups that are exempt from eligibility. One of them are university students who many of them, I don't know if it's all of them, most of them, but I know many of them are they pay fees to the university that for a package of services that they receive, and one of them is dental care. So it's part of the package that they get, and they can't remove themselves from it because they're paying the fee for it. They're not eligible for dental care. So all these young people who should be able to access dental care are not going to be any better off than they were 2 years ago. So so that's one thing. Income testing, I think, is a really degrading insult to Canadians to have to submit themselves to a means test to see whether they should be able to have access to dental care. Everybody knows that dental care is it's not like it's not something that should be an option for people. People should be seeing dentists regularly. They should maintain their dental health. And in order to do that, they need to be covered by a dental plan. So that's one thing. That's one of the key awful things about the dental plan. The other thing that just quite frankly, I find also insulting is that Sun Life has been contracted to administer the dental plan. I don't know who all was involved in lobbying the Liberals on this. I'm obviously the insurance industry. I'm sure that the dental associations were also actively involved and were, I know that dentists were not in favor generally of being, having their services covered under a public plan. So probably amongst the dentists, there was a split between dentists who wanted just a straight up commercial insurance arrangement and those who wanted not a nonprofit insurance, so Green Shield or Blue Cross or whoever. And so that's my understanding of what's a lot of the debate was within the dental profession. And it is no different than the debate that was happening in 1962 when we were talking about Medicare. So that dynamic is obviously quite active. I'm sorry that the dental plan has been implemented. I think it's going to be very, very difficult. And this, I guess, is the third criticism I would have of it. It is not. I think it's going to be really, really hard to expand and change the dental plan and create a universal dental plan, that the type of plan that we need, because the insurance industry is so heavily invested in it. And in the meantime, we've also seen dental access to dental plans, employer-sponsored plans, has been also eroded over the years. So it's a mess. I know that there's somebody on the call who also might have some knowledge about this, and I don't know if Keith Lowe is on the call, but I know he's had some thoughts about it as well.
And we've done a webinar or 2 or 3 even on the dental care program with Brandon Doucette, who's the founder of the Coalition for Dental Care, and he is fully aware of the limitations and fought really hard for it. So I suspect he probably wouldn't disagree with what you're saying. Nonetheless, it's still better than nothing. So I'm just going to go back to some of the questions. What about the whole question of reporting under the Canada Health Act? Because it seems like the only power that the Act gives the government is the power to withhold funding. There's no real punitive measures. There's no way to go after provinces that violate the 5 main premises. And I wonder, what are we learning about how universality works in each province territory, and what we could be doing better with the annual Canada Health Act reporting? And you can go and look at that online, and you can see which provinces are the most egregious disregarders of the Canada Health Act. But I think some people think that there's an enforcement capacity, that if you don't follow the standard, you're somehow illegal, and that's not necessarily the case. I wonder if you could elaborate a bit on that, Colleen.
Well, you're right. This has been an issue for many, many, many years. And in fact, I can't remember what year it was, probably in the mid-90s or sometime around there, the Canadian Health Coalition, I think it went to the federal court and asked for a ruling that would force the federal government to resolve that situation with the lack of reporting by the provinces, and they lost. They didn't. They got nowhere at the federal court, but it still is an issue that provinces don't like to report, and even the ones that do report, the reporting is very it's sort of, you can almost feel the contempt from the provinces because of the sort of shoddy reporting that happens. But the reporting is important because it's like the federal government also will investigate provinces for things like extra billing and user charges, violations of the Canada Health Act. But it's a complaint-based system, and we know that those are also always very weak. And so there's not only is there problems in the provinces reporting, but the federal government also does virtually nothing to ensure that there is some higher level of accountability for the money that's being, the federal dollars that are being spent. And they're not going to the provinces. I mean, can you imagine if the federal government said to Saskatchewan, we want to do an audit to see what's going on? And so that's I just think that's a weakness in the Act. But I also,
what about the question, like we've seen in the last year or so from Danielle Smith in Alberta, from, you know, various provinces, a lot of pushback against the feds. You know, this is our business, you need to butt out of our business, like you know, and yet the federal government funnels a lot of money to the provinces for healthcare. So when I hear that discourse from provinces, I find it confusing. Like, what is, we don't have provincial autonomy on healthcare because the federal government plays an important role in healthcare.
well, there always is this never-ending debate, which I find one of the most obnoxious things about health in Canada, between the federal government and the provinces about jurisdiction, and the provinces, you know, have argued endlessly that it's their jurisdiction, the federal government should butt out, just give us the money. And the principle with the Canada Health Act wasn't, we'll give you money and please use it the way it's intended to be used. The principle was no cash, no compliance, no cash, right? You don't comply with the act, you don't get any money.
And now it's the opposite, it seems. Now it's no compliance, no cash. Oh, wait, anyway,
no,
I think it's the opposite. No
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 cash.
cash, no compliance, sorry, yeah.
And the provinces started to say that in the 1990s. If you remember, under Mulroney, there was just a slash and burn, you know, in terms of health transfers and so forth. And the provinces basically said no cash, no compliance. And so and this sort of reminds me about a question that somebody else asked that sort of got lost in the shuffle, and that was about amendments to the Canada Health Act. And I know that this is a very controversial issue because people are worried that if the act is amended in any way, that it will be a step back rather than a step forward. That there are, the Canada Health Act was passed in 1984. It is quite an old piece of legislation now, and the healthcare system is not the same as it was in 1984. In addition to that, the Canada Health Act never was supported by a base of regulation. So there are two regulations attached to the act. One is the ban on extra billing, the other is the ban on user fees. And so the Monique Béjean, when the legislation passed, she began consulting with the provinces about the regulatory framework that would give guidance on the Canada Health Act, how to interpret it, you know, and so forth. And the provinces just gave her a rough go. It was very, very difficult. And then the writ was dropped, and then we got the Conservatives. And so there is no regulatory underpinning of the act. And that's something I think that is unfortunate, because what it has meant is that the act is subject to interpretation. And one of the things that's subject to interpretation, more than anything else probably, is universality. And so so if the act is subject to interpretation, enforcement also is a big problem. And most people will not know this, but there were amendments to the Canada Health Act in, I think it was 1996, when the federal transfer legislation, the CCHT, Canada CHST, when the CHST was introduced, one of the sections in the act dealt with transfers, cash transfers for what were called extended health services. And these included a lot of outpatient services like physiotherapy, like counseling, and so forth. And David Dingwall eliminated that section. And so there were no longer any transfers specifically for those extended healthcare services. That was a step back. So I understand the nervousness around amendments to the act, but there have to be some changes. There have to be changes on the transparency issue, in the accountability from the provinces on how the money is being spent, how they're adhering to the act, all of that. And there also has to be some clarification, and we have to get away from the idea that the Canada Health Act, which is the key legislation governing our healthcare system is subject to interpretation.
So Keith Lowe is with us tonight, Colleen, and he texted in to ask a question. He says, the insurance industry is deeply invested in the recent non-universal means-tested dental payment plan, while universal Medicare enjoys huge popular support. And I think that is true. I think it's very Canadian. I think it goes to the whole thing about Tommy Douglas being voted the most, significant and popular Canadian. So huge popular support. And political capital. Can support be mobilized for a fully universal dental plan and other much needed additions to universal Medicare? So that's from Keith Lowe. And a similar question from another person who is asking about what could be done to repair or modify dental delivery and shore up, and yet another question, shore up support for pharmacare, which is in a kind of a limbo now, going to committee. The Liberals will, what they call rag the puck in hockey lingo, they'll drag it out. So you were saying earlier on an optimistic note that there are things that we can do. What are those things, do you think?
One of the things, and I know that this is really hard, and it is hard, but I think that, one of the problems with our healthcare system, or maybe it's our political system, is it's fragmented across the country, right? You have, we're all in different provinces. We all fight, within our own provinces against privatization, for improvements in accessing primary health care, all of these things. We do that at a provincial level. We often forget that we do live in the same country and we are governed by one national government. So I think that some of our political energy on pharmacare in particular at this time really has to be focused there. But I also think that we have to begin pressuring our provincial governments, because of the way that this is going to roll out is going to be on this stupid formula, which I hate, that so many provinces have to buy in, and they're not, it's that to me, that's worrisome. The provinces never agree with each other, let alone the federal government. And so we'll see which way that goes in. But even British Columbia, I would argue that British Columbia has the best pharmacare program in the country. And it is way short of the mark, but it is, it's the best for a lot of different reasons. And but it isn't universal. It isn't all the things that we need. British Columbia, I haven't heard our health minister take a position yet on national pharmacare and whether BC is going to be on side. And I think a lot of provinces are being a bit too coy and need to be pushed to take a public position and help people in their provinces push the federal government to get on with it and to, push this thing forward.
I think there are talks with BC and with Manitoba, two NDP governments, obviously. But here in Quebec, where the government has said it's opposed to pharmacare, the civil society and the union movement has come out strongly in favor of the federal pharmacare proposals, much to the surprise of many of us. So I think you raise an interesting point. Somebody texted in to say, for your information, the Canada Health Act has in fact been amended a second time in 2017. Removing the RCMP from an exempt group status without opening a Pandora's box. So apparently that was done, and I'm surprised to see that. I didn't know that. Thank you for that. I'm so impressed with the depth of knowledge and the insight of the people who are with us on this webinar. So thank you very much for joining us. And I'm just going to try and scroll through because there's now quite a few questions accumulated. The importance of dental care, obviously, because your mouth is is critical to health. And it seems so blatantly obvious that this is something that needs to be taken very seriously. Okay, so here's some that I read the Keith Lowe comment. How about your thoughts on strategies on dealing with doctors and dentists pushback? What has historically worked and helped? And a thank you from Crystal Lewis, who says, thank you for your insight so far.
Thank you. I think that one of the really positive things that happened on the physician front was the establishment of Canadian Doctors for Medicare. That's such an important organization, and their activism sort of goes up and down, and I think it's uneven probably across the country as well. But I think that it is super important to encourage doctors to become members of that organization, because progressive doctors get drowned out by the sort of very opportunistic policies within the medical associations. And medical associations are, doctors are so powerful in the discussion about healthcare. I think that they should be less powerful. I think that there needs to be equity in the discussion around healthcare, so that doctors are not the final word on what should or should not be done. I think they're an important voice, but I don't think that they're the only voice. And so that's one thing. I also think that with the dental profession, you know, I'm not as familiar with the dental profession as a sort of political force, but I know that that the lines amongst them they look similar to within the medical profession, where you have, you know, dentists who are dealing with the private insurance industry. They don't like it. They feel in a sort of conscientious way, maybe, that that nonprofit dental insurance is better than the commercial insurance industry, et cetera. But I think that, I don't know how you get the dental profession on board for dental care. I don't know. I wish I had some ideas about it, but I don't. But I do think that with the medical associations, that I think the medical associations should be challenged as being poor representatives of the medical profession, first of all, because they are. In our province, we have the medical association has really poorly served physicians who a huge percentage of doctors here, just like everywhere else in the country, have wanted to get off the fee-for-service wheel for years, and they've been blocked by the medical association from doing that, from my perspective. And or at least that the medical associations have made it very, very difficult to get off of that payment system. And the payment system, fee-for-service, is one of the Achilles heels in our primary healthcare system in particular. So the medical associations have played very often a negative role. When the Canada Health Act was introduced in 1984, the first charter challenge under healthcare came from the CMA and the Ontario Medical Association, who worked together and encouraged all other provincial medical associations to join them in a charter challenge, arguing that the Canada Health Act infringed on their constitutional right to bill patients what they wanted. And so the doctors, the organized profession, or the organized medical associations, have not played a positive role. They're not regulatory bodies, they're political bodies. And so they have played a fairly negative role, which is, getting back to what I said at the beginning, the establishment, the founding of Canadian Doctors for Medicare was really important, and they should be encouraged and supported to become bigger and more active.
And they are with us tonight on this call. So I hope they're feeling the love from us. And in the chat, there's a link to their webpage, which Tracy has kindly put up, because we are big fans of the Canadian Doctors for Medicare. And in fact, recently, when the Canadian Medical Association organized a so-called series of town halls about the public versus private relationship, the Canadian Doctors for Medicare joined us and others in our opposition to these town halls, which were held across Canada, which were basically, we thought, just a thinly disguised exercise in PR by the CMA to promote privatization. So please do check out the Canadian Doctors for Medicare. And if to any physicians who are on this call, or anybody who is related to a physician, gently, we're nudging you towards the Canadian Doctors for Medicare. The president is Mélanie Béchard, and Dr. Mélanie Béchard and Dr. Bernard Ho. These are wonderful people and big supporters of public health care. So going against, the culture of these medical associations. And once again, I just invite you to check out the Canadian Health Coalition's web presence and join if you haven't already. I'm just going to go back to some of these questions now. We're running up against the clock, which is inevitably what happens on these events. But thank you very much for participating and putting questions in. Cheryl Ann wants to tell you that you're doing a great job, Colleen. Doing a fabulous job, which is always nice to hear from participants. It's not easy to do a webinar on such a complex subject. And I know in the mind of an expert like yours, it's sometimes probably hard to sort through because there's so much information in the hard drive there. Let me see now. We have one dental provider in a place called St. Anthony. This is Elizabeth, who says there's basically no care in certain parts of the country with regard to dental care. And somebody wants to know more about Brandon Doucette, who is the Coalition for Dental Care, and some people have called it Tommy Douglas of dental care in Canada. He's just written a really interesting book on the subject that I would recommend for people who haven't seen it. It was just published recently. Okay, here's a question. This is an interesting issue. This has come up for Labor, some of our allies in Labor, and Kat Lanteng of Blood Watch. What impact does Canadian Blood Services privatization of the services in Canada? What does this mean? What impact will that have on pharmacare? And I would ask overall in general, because we now have private for-profit plasma collection, and it looks like we may be moving towards more privatization in general with regard to blood-related products.
I feel I'm not really the one to answer that question. I have a lot of concerns about what's happening on that front as well. And I also know that there's been quite a long road that has got us to this place on blood services and blood collection, and so particularly. But I don't want to answer the question. I'm sorry. I just don't feel confident enough to go into any great detail, except to say that I'm as pissed off as everybody else.
And also there is an organization called Blood Watch, which people can go and check out. They've done a lot of good work on this. And that an organization that was founded during the tainted blood crisis of the 1980s, a disgraceful episode for the Canadian Red Cross. Here's a question. This is a bit of a difficult one. I've long felt that we'd be stronger as a country with a national healthcare system rather than one provincially managed or deliberately mismanaged. Wouldn't it help for the CHC and provincial coalitions to work more closely? Well, yes, it certainly would. And we are cooperative between us, the provincial health coalitions and the Canadian Health Coalition. The provincial health coalitions have representation on our board, and we participate in their meetings. But you're right, it's a really important time. We have a year left of this agreement between the NDP and the Liberals, and that would be a very useful thing to strengthen, is that relationship. But I wonder how you see it, Colleen, the two sets of groups.
I completely agree. And years and years and years ago, I was having dinner with a couple of friends, both of them lawyers. And one of them, we were talking about healthcare because that's all I ever talk about. And we were talking about the debate. Oh, there had just been the whatever it's called, the Canadian Bar Association had just published this wonderful, wonderful booklet that everybody should read if they can get it, called What's Law Got to Do with It? And they were talking about what does the Constitution actually say about jurisdiction. And anyway, we were the three of us were talking about this, and one of my friends said, well, here's what I want to know. Why do we even have provinces? And I thought, oh, that's an interesting question. And it is actually, and in healthcare, it is a huge problem. And, the at the beginning of the whole struggle for a national healthcare system, a national health program, that's what it was called, a national health program. The CLC was one of the leading lights in the struggle for a national health program. And instead we've got provincial programs, and we've got all these fights that go on. So I often compare our system to the system in other countries. And I think that I don't want to exaggerate and say that it's, a great weakness in our healthcare system, because there are things that make sense that would be administered provincially, in the health sector and so forth. But there are things that we really pay a high price for the type of system that we have. And I'll give you one example, and this is just a personal thing. I was in Europe about 5 years ago, and I fell and broke my jaw. I was in Amsterdam, so I had to go to the hospital there. And one of the things I found out is that when that happens, you have to go through all this private insurance stuff, right? And make sure that all the ducks are lined up, so you're not going to have to pay an arm and a leg for the hospital stuff that you had to access when you were over there. And I found out that within, first of all, amongst Commonwealth countries, but also across Europe, that countries have these systems of reciprocity. So if a person comes to Canada from Germany, let's say, and something happens to them, their government would automatically just pay whatever it was. There's a system between England and Spain, between the Netherlands and Australia. But we're not part of that. And the reason is because we do not have a national healthcare system. So there would have to be these arrangements, reciprocity arrangements with every province, which infringes on federal jurisdiction in relations with other countries, et cetera. Anyway, so that's a disadvantage. And yet we do have a system of reciprocity within Canada. So if you're from BC and you get sick in Ontario, they will reimburse, BC will reimburse Ontario, because they have a system where they worked out all of the reimbursement, the level of reimbursement. So if it costs $600 to be in a hospital in BC and you're in hospital in Ontario, it'll be exactly the same. So there's this system. So we don't have, that's just one small example that really bugs me, that we're not part of this international system of reciprocity on healthcare amongst all of the nations that have universal healthcare systems.
And I think, is that called transferability in the Act, potentially?
In the Canada Health Act?
Yeah. Isn't that what's meant? Like what you just described, if you fall and break your leg in Quebec, you get but you're from Ontario, then there's a reimbursement system.
Yeah. I
Because
think
I'm going to use that as a segue, awkwardly, as I just did, to say that we're going to do the other 4 sections of the Canada Health Act. Each one is going to merit a webinar in the next couple of weeks. And I'm just going to mention the dates, because we're hoping that you will join us for further discussion of the Canada Health Act, because it is 40 years old, and because in many ways it defines the country and the ethos of fairness, which I think characterizes most Canadians, the desire for fairness and equity in the system. So on May 28th, we're going to talk about comprehensiveness with Catherine Farrellbeck. We're going to talk about public administration with Greg Marchaldon on June 4th. And coming up immediately on May 7th, we're going to talk about portability with Antonia Maioni, and finish off with a double webinar with Jane Philpott and Colleen Flood, another Colleen expert on healthcare, who's the Dean of Law at Queen's, and Jane Philpott, who is the head of health sciences at Queen's. And they're going to close off the series of webinars on the Canada Health Act. And all of this leading up to the pièce de résistance, which is the symposium on June 20th at the University of Ottawa Law School, with various researchers from across the country presenting their work on the state of Canadian healthcare and the Canada Health Act. So we're going all out on the Canada Health Act here on here at the CHC. And I think if it's okay with you, Colleen, I think maybe we'll just close off now. I wondered if you wanted to make a parting comment before we say goodbye to everybody. And I know we have come nowhere near, the definitive event on this subject, but I think it's important to have broached the conversation, and we will try and find ways to keep the conversation going. And we'll put this webinar up online so people can listen to it and pass it on. So I'll just hand the microphone back to you virtually, Colleen.
First of all, I want to say thank you. I just went through the questions on all really, really good questions and comments. And so thank you so much. One of the last things I just wanted to say, and this is not to do with universality, but one of the things that happened when we got a universal healthcare system, and I put it in quotation marks for all the reasons that we know, but Canadian Health or the Canadian Labour Congress and all of the provincial federations of labor, one of the key points that they made when they were submitting to the Hall Commission up to 1962, up to the report, they argued that it was very important to have as a central recognition that a high quality universal healthcare system depends on high quality working conditions. And so that's something that I think is, really well understood amongst healthcare workers more than anybody. But also the fact that we got the kind of healthcare system that we did, we talk about the benefits to us as families and individuals and sort of generally society, but the other group that really benefited from that were the people who work in the healthcare system, because it was largely unorganized prior to Medicare. And the release of money from the federal government into the hospital system, particularly at the beginning, meant that that there was more money to pay people decent wages and also to increase the workforce. The money that was released into the hospital system just had this dramatic impact on the number of people working in the healthcare system. And the CLC, which was one of the leading voices in the struggle for universal health care, really linked the importance of high quality working conditions to the high quality of care that Canadians deserve. So I think that in all of the discussions that we have about all the principles and the importance of the Canada Health Act, that we also should keep in mind that we benefit because of our access to healthcare services, and the money that's used to fund the healthcare system enables provinces, enables hospitals to hire workers, enables people to get jobs in our communities as healthcare providers. That's all I want to say.
And
So
that is what Pat Armstrong, who is sort of the doyen of long-term care in Canada, says. She says the conditions of work are the conditions of care.
that's right. That's
And
exactly.
it's a very wonderful way of putting it. And it's exactly what you're describing. Thank you very much for that, Colleen. And thank you for joining us, jet lagged as you are from traveling back from the UK. A big thank you to Tracy Glynn, who coordinated the Zoom technology for us and the Q&A and put all that information in the chat. So we hope to see you again on May 7th with Antonia Maioni talking about portability in the Canada Health Act. And hopefully maybe even at the research symposium on June 20th. Thank you to everyone for joining us tonight and for your wonderful insight and care for Canadians, all of us, Canadians and Quebecers. Merci à tous et à toutes. Et il ne reste qu'à vous souhaiter une bonne soirée. Thank you very much to everybody. Hope to see you soon.